Hello everyone, my name is Alisha Linehan, and this is my presentation on the ethical implications of withholding care from elderly ICU patients and its effects on nursing. My presentation is based on a study by Bertrand Godet and multiple other authors called Withholding or Withdrawing of Life-Sustaining Therapy in Older Adults Greater than 80 Years Admitted to the Intensive Care Unit. This study was published in the journal Intensive Care Medicine in 2018. The study examines ICU patients 80 years or older in 21 different European countries and in 309 different ICUs. These patients were followed for 30 days in the ICU or until their death. One of the main points of the article is that our population is aging around the world. As life expectancy is increasing, so is the average age of ICU patients. And this increasing age of ICU patients is bringing up all new questions of quality of life and end-of-life care. Many of these older patients are admitted to the ICU without clear goals or expectations for their care. And this lack of expectations by both healthcare providers and patients and their families complicates decisions to withhold or withdraw care. This study also looks at the effects of culture on decisions to withhold and withdraw care. The study found that culture affects physicians' decisions to withhold care, as well as physician religious preferences affect their decisions to withhold or withdraw care. The study finds that this is an appropriate application of cultural preferences, that instead decisions to withhold and withdraw care should be based on the patient's clinical presentation as well as the patient and their family's wishes for their care. The study found that countries with higher GDPs were more likely to withdraw or withhold care, while countries with lower GDPs may inappropriately allocate resources by not choosing to withhold or withdraw care. So basically this means that in an ICU with limited beds, those beds may be taken up by patients with poor prognosis who have had a long stay in the ICU, while patients who might benefit more from those beds in the ICU are unable to be admitted to it because of this hesitation to withhold or withdraw care. This study presents a solution for some of these issues. First of all, the study claims that decisions to withdraw care should be influenced by the expected mortality of the patient's personally defined quality of life, as well as the patient's potential level of functioning upon discharge. Note that none of these things are a physician's own cultural preferences or religious preferences. The study also claims that upon admission to the ICU, physicians and patients should discuss their goals and expectations of care, possible outcomes of the stay in the ICU, various levels of treatment progression, and that this conversation should ideally take place within 72 hours of admission. The study brings about multiple ethical considerations. The first is the ethical principle of respect for autonomy, and this means that each patient's personal preferences should be the most important factor in determining that patient's plan of care. We should be inquiring into patients' personal preferences for their care, and we should be faithful to abide by those patients' personal preferences in designing their plan of care. Next is the ethical principle of quality of life. Now, quality of life is completely subjective. Each patient has to decide for themselves what they consider to be quality. And we need to be having conversations with our patients about what kind of life they're willing to live with, and that should be influencing what decisions to withhold and withdraw care. So physicians and other healthcare providers can't just decide for themselves what quality of life is. Each patient gets to make that decision on their own. So the final ethical consideration is a little more difficult than the first two, and this is the ethical principle of justice. So justice is the idea that resources should be allocated to do the most good for the most people. So this can be directly applied to that point in the study where they found that countries with fewer resources, the ones with the lower GDP, were less likely to withhold or withdraw care. So if we're using the principle of justice, we're giving ICU beds to the patients who can benefit from them the most. Now, the trick, of course, is to use both the principle of justice with respect for autonomy and quality of care. And that's where these ethical considerations can get really, really complicated. But ultimately, ideally, we're always falling back on respect for autonomy by allowing the patient to dictate their own care and to define for themselves their own quality of life. So what does this mean for nurses? Well, just like physicians, we nurses all have biases we need to counteract. And as we're caring for our patients, we need to make sure that our own cultural preferences and our religious preferences are not influencing how we're caring for our patients. As nurses, we should be encouraging our patients to voice their preferences prior to and during ICU admission. Now, as we all know, once a patient's on a ventilator, it can be very difficult for them to voice their preferences, and it can be difficult for us as healthcare providers to uphold the ethical principle of autonomy of care. So we should be encouraging patients at every stage of the healthcare process to be thinking about what kind of end-of-life decisions they would like made for them, and to be thinking about what kind of quality of life they prefer, and to, of course, be making sure that those preferences are documented in the appropriate legal documents, such as a living will. And finally, we should be advocating for honoring our patients' preferences. Once they've expressed to us what their preferences are and they have legalized those preferences, we should be doing our absolute best to make sure that each patient has their own preferences followed as we're making decisions for end-of-life care and for ICU care for these patients. So how am I going to take this home to my own ICU? Well, first of all, I need to educate my patients. Even before they get to the ICU, if you can do this for your family members and your friends as well, is encourage everyone to be thinking about what kind of end-of-life decisions they want made for them, and to be encouraging everyone to make sure they have a living will that expressly communicates that. And they need to be having conversations with their family about what they want as well. I need to be advocating for my patients in my home ICU, and I need to be making sure that once my patients do express what kind of care they want, that I am advocating for their physicians to honor those preferences. And finally, I can act as a liaison between my patients and their families and physicians. I found that sometimes families are more comfortable with communicating their preferences to their nurses than they are to their physicians. For some reason, there's a certain amount of discomfort that can happen in the conversation between families and physicians. So as their nurse, I'm in a special position to listen to what they're telling me, and then to make sure that I bring the physician into that conversation as well, especially if I feel like what the family's telling me and what they're telling the physician aren't necessarily matching up. So I really hope to be able to utilize what I've learned from this study in my own practice at home. I do see a lot of patients over the age of 80 in my ICU, and I do see families and patients struggling with these questions of quality of life. And I think that this study will help me better communicate to them the options that they have, and better encourage them to express to their physician the kind of care that they want and the kind of quality of life that they desire. So finally, this slide is my references for this presentation, and thank you so much for your time.